In patients with metastatic non-small cell lung cancer or even now squamous cell carcinoma, if they have high PD-L1 expression, meaning greater than 50% immunohistochemistry, then they are certainly eligible to receive pembrolizumab alone. And that is certainly a very appropriate option in these patients. Where we add in a triplet combination, which is chemotherapy plus the pembrolizumab, both in non-squamous and squamous, would be in patients who are less than 50% PD-L1 positive. Now, I will admit in my clinical practice, for patients with high PD-L1 above 50%, I still sometimes have given a triplet regimen. And I do this in cases where the patient is imminently threatened, where they have extremely high tumor burden, and I fear that if we don't act quickly to debulk them, they'll run into some serious trouble. So oftentimes you have to use your clinical judgment on which are the patients that you really need to be multiply aggressive for and give them that triplet regimen, because the response rates in high PD-L1 are very high, both in squamous and non-squamous non-small cell lung cancer. Adding in pembrolizumab to chemotherapy is usually not typically done. More often than not, we're adding chemo to a monotherapy if it's not acting fast enough. But in some cases, if somebody's already started on a platinum doublet, certainly given the data from KEYNOTE-407 and KEYNOTE-189, you can add pembrolizumab in to enhance the response, or certainly if they've already gotten through treatment and you want to give them the immunotherapy during maintenance, that's certainly also an option. KEYNOTE-189 demonstrated, which was close to 660 patients with non-small cell lung cancer, adenocarcinoma generally, it demonstrated a significant benefit in progression-free survival. The median PFS was 8.8 months versus 4.9 months, and the hazard ratio was roughly 0.5, and this was highly statistically significant. We also saw a significant increase in overall survival. In fact, the median wasn't even reached in the triplet regimen arm. So this is certainly something that we want to consider for our patients, because we know that adding in immunotherapy does prolong survival, both PFS and OS, and it also doesn't appear to add too much additional toxicity to our patients. In this patient, who has metastatic adenocarcinoma of the lung, she received carboplatin, pemetrexed, and pembrolizumab. And this would be the regimen that I would definitely choose for my patients who fit her profile. She has no prior history of any autoimmune problems. She has a relatively decent performance status and can tolerate the treatment, and she's compliant. She also appeared to have significant disease in the liver, and that actually indicated to me, even though she was high PD-L1, that we wanted to try to debulk her quickly. And that's why I would agree with giving the triplet regimen in her case. In KEYNOTE-189, across the board for all non-squamous non-small cell lung cancer, they looked at PD-L1 IHC and determined what their levels were. And across the board, across all levels, they had survival benefit. So certainly for patients below 50% PD-L1 IHC, this is the regimen to give them. If you're above 50%, as I mentioned before, the response rates are certainly higher, and they may have the greatest magnitude of survival benefit. So if you have a patient who is high PD-L1, KEYNOTE-189 indicates to us that this is certainly a very appropriate regimen that can improve survival. And again, your choice, you do have alternatives. You could, if this patient wanted to and was not imminently endangered by their cancer, you could consider giving them single-agent pembrolizumab. But in this case that we have before us, she was imminently threatened with huge amounts of tumor in her liver, and so I certainly think and agree that the triplet regimen would be most appropriate for her.